Okay, so we are at our eighth session today, Introduction to PCORI Methodology Standards. This session will be presented by Dr. Rebecca Johnson. Thank you so much, Dr. Rebecca. We can't really thank you enough for all your efforts. And now I'm going to ask Brother Abdurrahman to recite the prayer, and we'll get going. Thank you.
Assalamu alaikum, everyone. I'm going to recite a short dua. Bismillah ar-Rahman ar-Rahim. ربنا لا تزغ قلوبنا بعد إذ هديتنا وهب لنا من لدنك رحمة إنك أنت الوهاب. And the translation goes, O our Lord, let not our hearts deviate from the truth after you have guided us, and grant us mercy from you. Truly you are the bestower. Ameen. May Allah accept.
Ameen. Okay, and today's topic, after reviewing the skill set, is basically the known knowns, the access to care assets. So we are doing the asset mapping, and now we are putting this into the mosque context. So Dr. Rebecca is going to give us some overview as to what it means to count the assets within your own community. And PCORI methodology standards will be introduced in detail today, and then I'll briefly talk about the community programs versus research projects, inshallah. And basically, I'm going to let Dr. Rebecca talk about the details.
Yeah, sorry, I'll just get my slides up. So here we go.
Do you want to talk? Yeah, go ahead.
Yeah, and feel free to chime in, Fatima, whenever you feel that you want to. Okay, so here we go. Session 8.
So I'm on the skills of the community health worker slides. Okay.
Is that right? Yeah.
Okay.
Yeah. Okay. So present. Can anyone see those?
I'm so sorry. I wasn't even presenting. Okay. Do you want to present? Go ahead, please.
Can you see them?
Not yet.
Not yet. Okay. So
I can present. I forgot. I didn't even press the present button, and here I am with the slides.
Thank you. Thank you. That would be great. Thank you.
Oh, please. I very often I forget this thing. This just one last step. I don't know why I forget that. And I'm thinking, what's going on here? Okay, there. So here we are. Okay.
Apologies, everybody. I seem to fell off there. So here we go. So
there.
Yeah.
There.
Perfect. Thank you very much, Fatima.
Oh, please, absolutely. I'm so sorry.
That's all right. No worries. So, okay. So yes. So today we're focusing on. We want to sort of. We're moving. Yes. As Dr. Padella gave us a fantastic overview of. The sort of the Muslim as Islamic context, and also introduced the idea of mosque as community. We're beginning to sort of explore that. So the skills that Fatima and I wanted to sort of highlight today is about, we're trying to increase your individual and community empowerment. So we're moving from more generic sort of health disparities sort of focuses to help you sort of increase your individual and community empowerment in terms of identifying own problems, strengths and resources. And as always, to ability to build connections and coalitions. And I've been so grateful to those of you who've have offered to present what you're doing, and Andy's presentation, which was lovely. It was fantastic, because I think these are all examples. You are the people with the assets in many ways, and the connections between all of you are as important as the connections I think you're going to make with the mosque communities. And also, I think we'll sort of generate a sort of coalition of ourselves. We're partners ourselves, and we're sharing knowledge and learning from each other, as Fatima said so well in that lovely email that she sent round to us all. And I do appreciate Fatima encouraging words of encouragement, because I know this is hard work for all of you. You're doing a lot of listening, and there's a lot of information sort of coming your way. So yeah, there's a lot of reflection. So I do appreciate the energy that Fatima brings to the table and enthusiasm. I do.
Oh, thank you. No, you're doing phenomenal job. I don't know how you're pulling this off, honestly. Very hard.
We'll keep going. All right. Okay. And also, I do want to say is that, I mean, obviously, any questions you have, either things you've thought about, from Dr. Padella's presentation, or things that are popping up, do share them in the chat box, and and Fatima and I will do our best to answer those. Okay, so yes, that's the focus today, really, and also again, sort of bringing PCORI in to see how it fits with that health disparities picture, that big picture, and also sort of just exploring the idea of health equity framework a little bit more, so that you've got a tool which you can begin to think, actually, who I'm really talking to? Which members of the community am I empowering? And my feeling is that we're talking about you as members of this group, sort of talking about improving access to care. But I also know you have your own interests, as Andy so beautifully just sort of told us about last time. So there are all these specialities that you have as well. So we're trying to bring all those things together. So if we can have the next slide. Yes, and so this ability to participate in individual and community assessment. So there's assessing yourself and your own skills and yourselves as assets for this project. And then there's, as Fatima and I think, particularly Fatima and the team at Worry Free learn more about you, that helps them to put you in touch with the right mosque, as it were, to match you to do that matching and sort of think about which ones you'll have an affinity with. And then we're also going to move through and help you begin to think about the community and the knowledge that you might like to sort of find out about the community and the neighborhood before you touch base with the leaders of the mosques. And I think it came over very strongly from Dr. Padella's talk yesterday that your first task is to, the Worry Free will put you in contact with the mosques and leaders, and then it will be your role to explain the project, and potentially, we'll have to talk this through, but potentially then ask for access to other members of the mosque community. So there are these layers that we need to sort of think through and prepare you for. And that's why asset mapping is very helpful, because it will help you to sort of be knowledgeable about the neighborhood, go and ask the right questions of the leaders, and then think who else you might want to reach out to. So this is why, project management is going to become quite important as we go forward. So the next session, sorry, this is session 8. So the next session will be we'll follow up on orientation to outreach. That's what we'll do in the next one. Okay, but let's just sort of ease into today. Happy Tuesday. And I'd like you all to think about, if you were a book, because I've picked up from you all that I think a few of you have mentioned you like reading. I love the prayers that we have at the beginning. So the sort of, that's really, I found it very inspiring, and it's a very, and so if you could just sort of say, if I was a book, I would be. So I'll give you an example. If I were a book, I'd be a notebook, because I like to jot things down as I observe and sort of make little notes. So could a few of you just sort of, as a scientist, as an observer, I'm always noting. Scientists are nosy, unfortunately, so we're always noting things down. Okay, so if some of you could share, that would be great.
I can go first. If I were a book, I would be a journal, because I love to write about stuff, and I have a pretty imaginative mind, so I guess I can just write like fantasy stuff and whatnot. So yeah.
Oh, that's cool. Thank you, Asna.
I can go next if that's okay.
Please do. Yeah.
Yeah, if I were a book, I would be a coloring book because I like to color and I like colors. And if it would be a coloring book, it would be with stickers, so it can be more fun.
Yes, I like stickers. I'm very pleased. I have young nephews and nieces, so I enjoy their sticker. That's nice. Thank you.
Hi. Assalamualaikum. This is Doria. But if I were a book, I would be a self-development book because I like developing myself and finding ways that other people can develop themselves.
That's really cool. I like that. That's a nice one. Yes. Thank you, Jawara. Would anyone else like to share?
I can go ahead and share. I think if I were a book, I would be like a guidebook because I like working with my hands and I like showing people how to figure things out.
I like those. Are good. Those are all cool. I like those. You see, I now know that you're all listeners because you told me that, and that you like guiding people and navigating, and also sort of being accessible. Because the nice thing about colouring books is, of course, they're very accessible. And yeah, so that's lovely. Thank you guys for sharing those. That's really good. Okay, so I noticed none of you said you wish you were a medical book, so there we go. So, or an encyclopedia. Actually, encyclopedia might be quite a nice one. Actually, as well. All right, if we could have the next slide, Fatima, that would be super. Okay, so I just wanted to sort of do a little bit of a knowledge check. So I know it's a little while since we talked, but obviously Dr. Padella's slides followed on from the sort of what we've been saying. So I talked to you about the 3 golden rules of research engagement, and I said they were being informed, trust, being, showing trust and respect. And these actually are also key principles of engagement. Now, can you, Dr. Padella presented the 5 principles of research engagement. Can you name the other 2? And if you want to use your chat box, that would be fantastic. Thank you for sharing that. Listening is very important. It's not a standalone one, but it is part of the principles. Yes, co-learning and partnership. Yes, those are the ones that I hadn't talked about, and co-learning and partnership. And Fatima, is it reciprocal relations as well?
Yes, reciprocal relationship, correct.
Yes, okay. Reciprocal relationship. So yeah, so that's what we're going to focus on today. We're going to begin to think about, we talked quite a lot last time we met about behaviours and nice, respectful ways to communicate. And actually that came up, we'll come back to that because I think it would help a lot if we all thought about how to approach the leaders of a mosque respectfully. I think that can help if you write a letter or put yourself in a position of writing a letter. I think that can help, and we could share that in terms of, because the other thing about working as a group is it would be nice if we sort of all have an idea of what we're doing when we're going out there. There's a sort of shared vision and a shared behaviour. So but partnership, reciprocal relationships are what we're going to sort of think a bit more about going forward as well. Now, following on from what Dr. Padella said, which of the following have made the biggest contribution to date in the process of sharing mosque community knowns to a wider audience of health stakeholders who know nothing about Islam, Muslim faith, or the mosque community? Is it national database or local convenience samples? Cool. Cool, guys. Yes, that's right. It was the local convenience samples, wasn't it? And in fact, that was what was really interesting about well, for me, that was what was really interesting about what Dr. Patella was saying. Is he was saying that in many ways this is a grassroots data collection, data movement up. The national databases are not reflecting the experiences of mosque community members necessarily, or they find it difficult because they don't ask for religious specificity. They find it difficult to make distinctions. So I thought that was really interesting, because here you've got an example of qualitative data, which is things like, or qualitative methods, which is things like interviews, focus groups, structured and semi-structured conversations, actually providing a lot of insight into more insight than national databases. And I think this is yet another example of why it's really important to engage with the mosque community. Okay, so next one. So yes, so Dr. Padella showed this slide, and I think I want to emphasize, as he said, that patient and caregivers are at the core. But I also want to think about where you are, and I want to sort of think about that, because from your perspective, you're not the patient and you're not the caregivers necessarily at the core. Although we could argue that where you are caregiver, your stakeholders who care for patients. But so in the PCORI model, you've got the patient social capital to mosque. The patient social capital is the person, the teammates, neighbours, family, buddies around it, and then the client's network, and then the client's community, and then the larger community. And so that's the generic model, which if you've done social work training or you've done any, you'll have seen this model many times, where you've got the person and then it's about all these other sort of rings that impact the person's decision making and their access to care. In the mosque community stakeholders, you've got, again, the patient or the person is the centre, and then Dr. Badella he's clarified the specificity of those rings. So you've got the clinicians and researchers who connect with healthcare programs, but also the affiliates with the mosques provide the bigger system, bigger link to the healthcare system. So the role of the mosques as a link is made much clearer. So this is called social capital. So it's what people have. Everybody has assets. Everybody has assets, and it's just sort of emphasising all of how complicated people are in many ways. Okay, if you have the next slide. But what came through to me very strongly as well is that we need to think about other things in mind when we're talking about. I'm learning a lot, so I'm the yes, it's the unknown to me. So yes, he was arguing that religion and beliefs and so here we got beliefs regarding health. Things like holiday, these are all some cultural things which we also need to bear in mind, and we perhaps need to think about how cultural things are impacting people's healths. So here, I mean, these are all, we've got time in the country, which Fatima has covered very well, reasons for immigration, this whole idea, legal status, we've covered those things, and we know that they impact people's ability to access care. You often talk about the age of the family member. Now this says age of family members at the time of immigration, but there's also generational issues going on. Language spoken at home, that's come up in our conversations, and obviously impact of crisis events, very important at the moment. Family, education, and work values, and then. So all of these things we know. This is called a culturegram. So you're thinking about what else, apart from people's networks, this is about their beliefs and attitudes. What else is affecting and impacting their ability to access care? So what's missing from the culturegram, do you think? So remember, think about that working definition of vulnerable populations. So I've been suggesting to you that you're thinking about working with vulnerable populations. Dr. Padella was moving to a position where you can define a Muslim population. So if you're going to move towards a Muslim population, what aspects, can you think of other things that might be important, or do you feel that this gram covers them?
Family history of certain health conditions, diet,
Yeah.
nutrition,
Mhm.
some of the...
Yes, yes, absolutely, and those could be covered by holidays and special events, in the sense that that's where you often sort of find out about traditions, diets, but the family history is a really important one. Yes, I think that's very valuable, and yes, and if you have arrived in a country fleeing a war zone, you might not be able to find out about your family history, and so you won't necessarily be able to talk to a doctor about it. Often you get asked whether or not there's members of your family who have had things. So there is, yes, that a culturegram is helpful in thinking about other things that we should keep in mind. So thank you, Fatima. That's a really good point about the family history.
And sometimes people, when they migrate from particular, actually Bilal and I were talking about it today, and he pointed that out, that this indigenous, every areas have these specific indigenous conditions that are associated with that place. So in some places you have a prevalence of a particular perhaps disease. I know that there are these days there are a lot of genetic research that's happening in Iceland, because that country remains as a most homogeneous nature of DNA today. So that's one of the things which comes to my mind with going with the culture.
Yeah. No, thank you. So yes, I wanted to. Yes, so if we go to the next slide, that was just following on from what Dr. Padella was saying, and then just wanting you to help you think where worry-free fits in. So, and this is one of my favourite. This is a very, very social worker-y type of slide. So you have people in the middle who, age, sex, and constitutional factors. Then you have the individual lifestyles and social community networks. So this is a sort of condensed image of that those previous slides. But yes, the key thing that worry-free helps you to think about is access to healthcare, and the worry-free offers programs like wellness, a whole series of other programs, and this is what we're navigating. We're helping you to understand how to work with worry-free as individuals, with all your skills and all your assets, absorb and take on the worry-free assets, and be able to talk about all those things when you go and see the leaders of the mosques. Okay, so if we have the next slide. Okay, so today we'll continue.
Great. Sorry, but this is a great diagram where socioeconomic and cultural and environmental, and we know that socioeconomic and those conditions actually contribute 40% to the health disparities.
Mm-hmm. That's right. Yeah. So we're going to continue with assets, because I want you to really think about people, organizations, all the assets that you're collecting. It's almost like a sort of an egg hunt in some ways. We're collecting assets. And then I also want to introduce you to upstream, downstream, and midstream. Now, are any of you familiar with that idea as a framework for identifying health equity issues? Have you come across upstream, downstream, and midstream? No? Okay. All right. Okay, good. Okay, I shall all right, okay. All right, so what we're doing is we're beginning to help you to have tools to facilitate quality engagement, quality relationships, quality sort of engagement. and think about what it's a gift in some ways. It's what you can give, and it's what you can in return. And in return, you're asking, you're creating a relationship. So it's a gift is never a gift. It's always there's some very nice anthropology work about gifts, and the idea is that when you give somebody something, you don't expect a gift back, but there is you're establishing a bridge. You're establishing a relationship, and we want to make sure that you have the knowledge which enables you to establish that bridge, that relationship with the mosques. Okay, so if we have the next slide. So let's continue this idea of you as assets. And Javaria very kindly said that she would talk about her connections and her community, sort of the organisations that she's connected to. And as you listen, please make a note of the things that you connect to, or you can sort of think about the personal skills that you bring to the table as well. And we'd very much like other people to share their stories. Wasna has very kindly said that she will, and so that's on Saturday. And so but do get in touch with Fatima and myself if you would like to share a story, because I can't stress enough that you are the assets here. You're the ones that are you have the skills, and you're developing your capacity to engage. Okay, so please feel free to share, Jawaria.
Hi. Okay, so I'm actually stuck in a traffic jam. Yeah, so I was going to originally, I think, call Upna Clinic and get information for them, but they've been notoriously hard to get a hold of. But I will talk about my personal experience with a bunch of different organizations.
Yeah.
And I guess the things that I've seen and how I've seen like interconnections between everything. So I am a medical professional, so I've got like contacts with my clinic, with some of the other, like for instance, Upna Clinic, or from doctors who do a lot of like volunteer work, and they dedicate their time in helping people who might not be able to afford their services. So I have those connections. In addition to that, I was part of an organization called Al Maghrib Institute, which does like educational classes for cities across the world, but I was in charge of the Chicago branch for almost 2 years. So because of that, I connected with a lot of mosques and a lot of organizations, and we partnered with them to like provide aid, work on food banks, and on with just a bunch of different organizations. There's a lot. I don't think I could list them all out off the top of my head right now. But that did stress to me that there's a lot of resources that a lot of excellent resources that people try to organize, but are unable to connect with one another. And part of that has to do with like different cultural spheres. Part of that has to do with just the culture within the mosque, I feel like, too, that they feel like they only stay with their group of people or their mosque, and I guess there's not as much fostering of relationships in between mosques, too. Sometimes there is. Sometimes there's excellent programs, or like specific groups of mosques will be really good with one another. Sorry, 1 second. And yeah, so one really great example of like an interconnected project that I was a part of was there's a Hispanic Muslims group that started using their experiences with homeless people and their connections with other people who are like in the restaurant business and the massages to get food together and to get supplies together, and they would partner with masjids to get supplies together to provide this group that it's very hard for them to get care, it's very hard for them to get resources for them to get those resources. So I think that's like an excellent example of some of the things that we can do more of by connecting with one another and with the communities, so and within our own communities to help people who we've missed. So I don't really know what else to say. I'm also very distracted. So.
That's perfect. That's perfect. Thank you. No, that's right. And traffic jams, unfortunately, are a sort of feature of things, because we get stuck going from one place to the other, and the connectivity is not helped by the traffic. Yeah. So that's lovely. Thank you so much for sharing that. And I think I think you're highlighting how the difficulty of connection, the difficulty of, and also the importance of that too. So, and I love that example. But Hispanic Muslim, that is a really nice, a really great example, and bring sort of connections in order to around the issue of homelessness and food disparity. So, what does that prompt anything, Fatima, for you?
You know, it just hit me that I personally know, and I've seen a couple times. I went to the grocery store, and they were tossing out the food that was expired. So I think, and they commonly do that. And I know there are other organizations that are connected with the food bank, with the Northern Illinois Food Bank, where the Jewel Osco and Myers and these kind of big grocery stores, they actually donate their food before just before it expires, perhaps maybe a week in advance. Because they know that won't be sold, and they actually take that food and right before it expires, they would give it to the food bank so it can be used within that time frame. And we do not have that kind of mechanism in our community. And what Javeria was telling me right now, it just hit me that I personally have seen people, those shopkeepers, tossing the food because, of course, they can't sell it, and they don't have a mechanism to make that connection. And of course, they don't have the time to connect. But we can possibly be the bridge or other organization. There are other food pantry organizations that are out there in our community that can perhaps have this kind of a program where a high school student or somebody who would volunteer their time from the organization, they say that why don't I come out and pick up some of the food that you may have that is within a week or so, within 10 days would be expiring and you won't be selling, so why don't we give it to the needy people? Yeah, that can be that's a big thing.
Okay, so that's great. So I think yes, because we're as a group, we're sort of food banks are coming up quite a lot, aren't they? They're sort of being mentioned. So yes, having an overview. So and sort of this is what us as a group can help us each other to do, and sort of share examples. Or I think the other thing that you're both raising, which is really important, is the role of volunteers. And so that might be something when you go to the mosques that you want to ask the leaders, who and where are people volunteering? What type of volunteer work is going on? Because that's associational. Those are associational assets, and there's a lot of voluntary work going on where people are not paid, but a lot of really great stuff happening, and that sometimes gets lost. So in things, so that's really important. I think the third thing I took away from what Jaweera was saying is also if this. Maybe I can ask you this if you're safe driving is did you deal with the leaders of different mosques? So how did you deal with that? How did you sort of you must have had very different strong characters. So how was that something that you had to deal with, and did you come up with agreements with them, or how did you deal with that?
Yeah, so since we don't have our own resources, like we need a place to hold the classes, and we want to recruit people to attend the classes, we would partner up with different mosque communities. And sometimes that was really easy because they were very, very enthusiastic, and sometimes indeed it was very, very difficult. And we used a lot of different techniques. Like, as I'm sure everyone can tell, I'm very outspoken. So I would do my best to usually be the person who went and initiated those conversations. But sometimes because of gender, because of different belief systems, like that didn't always mesh well. So then I would what my response to that was like, okay, I understand. So I would choose one person who felt comfortable enough to learn how to deal with those people, and I would sit there and train them.
Mm-hmm.
And literally, I would just spend like maybe 2 weekends, 3 weekends, where it's like 2-3 hour calls, and just be like, these are all the things you have to go through, and this is your checklist. Okay, and then the next weekend, I'd be like, did you go through the checklist with this? Like, you know, this is the stuff we have to prepare to make this a reality, the class or the event or whatever was happening. So yeah.
Yeah, thank you. That's a lovely example. That's really good, and I think that's a very I love that example, because you're actually empowering those people as well, to the people you're training to be more. Yes, that's a very nice. You're creating more assets in a way in the organisation, but you're also very observant of the situation and what was needed. So yes, there's a very nice example. Okay, thank you so much. So that's really good. All right, so if you have the next slide, Fatima, we'll move on into. Okay, so now we're thinking about MPART, and which is the name of our project. And worry-free, obviously, and thinking about the organisational assets which are available to us to improve equitable access to care. And my understanding is that is patients, programs, strategic planning, and most importantly, I think, community connections. Oh no, actually no, there's one more. Fatima's knowledge is the other one. Fatima's amazing knowledge about the insurance systems and everything. So yes, so there's we've got a lot of assets, you know, in worry-free, and so what I think would be useful is for us to asset map worry-free, and so think about the core services that are being offered. I've just given that possibly well-being. I also think, I mean, we talked earlier on about how insurance is about the over 65s or the under 65s, and it's often about income. So thinking about the characteristics of the consumers or the patients that worry-free currently has, I think that would be a helpful thing, and also who you as ambassadors are going to feel comfortable with engaging, because after you've engaged the leaders, the question I think in mind is, are you happy with dealing with all age groups after that, or would some of you prefer to older sort of community members and some do younger ones? And that I don't know whether that's a discussion we should have to make it your workload less. But perhaps the first thing is to work out what the core services are that you would be explaining, and whether or not they cover, you know, where the programs fit, because it probably the programs will fit with different age ranges.
So, Dr. Rebecca, if we were to say that the core services are basically facilitating a PCOR research project, then but again, depending upon that kind of project would be there, it would differ, right? Yeah.
Yes, yes. It's we can come back to this. We can come back to it, but I think it's thinking about what organizational assets you are feeling comfortable taking forward when you have the conversations with the mosque leaders, and they may say to you as well, "Oh, we're only interested in you know, families. You know, anyone interested in programs for families," or they, you know, and so they might give you access to. So it's just making sure that you as a champion for MPART are comfortable with the populations that you're being steered really to engage with, or the issues that are coming up. So that's something we should keep thinking about as we go forward.
Is this the kind of I'm thinking this is the kind of a slide we would like to discuss with each mosque separately.
Okay.
What would you think? I
was thinking that we could do a summary of your. Okay. Yeah, but then we could fill it. That would be good. So a template like this would be something that they could fill in, because we were talking about, you know, so they could tell us what they're interested in. Yes, that's a good idea.
Okay, so we can have some core services like well-being and social services, and you know, healthcare access or health coverage, and health education, maybe perhaps. So those are some of the very basics, or new immigrant program that we work with. Okay.
Yes, that's right. Because I think because everybody's doing this for the first time, as it were, it's sort of taking small steps at the beginning and then getting more confident and sort of building and as you've introduced some services, you can then sort of, people will start talking to you and trusting you and bringing a relationship and ask you whether you have X, Y, and Z as well. But I think in the first instance, that first step is just being confident and knowledgeable is important. Okay, so if we go to the next slide. Yeah, so this is where I wanted to talk to you a little bit about upstream, midstream, and downstream. Yes, so basically this is a health equity framework, which is actually, the next slide is a bit better actually in terms of the imagery. Yeah, here we go. So this is, the idea is that there are three phases. There's downstream is you're trying to move upstream from behaviors to population health change. So you have downstream, you've got issues of disease and injury and mortality, and then you're trying to sort of shift it. You're trying to make it more equitable by addressing risk behaviors, neighborhood conditions, institutional power, and most importantly, of course, social inequities, race, class, and gender. So this is another way of writing that Robert Wood Johnson image, because we're trying to get, this is about population health change. It's not just describing what's there, it's actually becoming more active and behaving, accepting that we live in a system which isn't fit for everybody and is not equitable, but then doing adjustments or activities which help us move towards a more equitable sort of environment. So upstream are the interventions and strategies which focus on improving fundamental social and economic structures in order to decrease barriers and improve supports that allow people to achieve their full health potential. Whereas downstream, the interventions and strategies focus on providing equitable access to care and services to mitigate the negative impacts of disadvantage on health. So the downstream is sort of dealing with the situation we're in. The upstream is trying to sort of, the blue skies thinking is trying to sort of take us up. And so we all have to do all of those things. We're all trying to do, and I think that's what came out to me from Dr. Padella's talk as well, is that yes, we're having to deal with the disease and injury and mortality rates that we have, but we can do things which sort of can adjust those for future generations and lead to health population change. So if I'll give you some examples, that's on the next page. Next slide. So yes, midstream, for example, is increasing organizational and community knowledge and capacity to implement policies and practices that advance health equity. Whereas downstream is increasing individual knowledge and capacity on the impact of health policies on health disparities and increase behaviors that advance health equity. So we're midstream. We will sometimes sort of, that's what we're trying to do. We're midstream and we're trying to sort of push, because we're doing more than increasing individual knowledge and capacity. We're trying to increase organizational and community knowledge and capacity to advance health equity. So it's not just about the individual, it's about, you know, the structures that we all have to live within on a day-to-day basis. We're probably not going to do upstream, which is about increasing funding, because we don't have the power, unfortunately, increase funding for advancing health equity or policy, or coming up with new policies. But this midstream is very important because this is about empowering communities to identify the disparities and so that we can advance health equity. So have a think about that and read this article here, which is a lovely description of that. But I also like the idea of a river. So you've got this idea of a river. So it's this idea of flow and movement and process. And so everything we're doing with you is to try and help you move things upstream. Okay, if you have the next slide. So here's some examples. So this is actually National Institute for Minority Health. This is where these projects. These are their health equity projects. It's their health equity framework. And so what they've done is they've analysed policies impacts for areas of improvement. And so, for example, there's two. I've just given you two examples here. There's Project Thrive, which is about mental health, and then there's one about information technology, because information technology is seen as one of those things that's sort of going to solve health equity. Unfortunately, I don't think it's going to, but we need to. It's something towards, particularly in the time of COVID, it's something towards that. So, so what they did, what the Institute for Minority Health did, is they assess the state and for the health information technology, they assess the state and federal laws for an impact on health equity. So that was the upstream, that was the policy. And they analysed the implementation of the policies and the systems, that's in the middle. And then they sort of looked at those impacts on health equity, which is the midstream. And then what they did is they then worked with partnership in the community. And that's why I wanted to show you this, because what they did in this case is they put together a coalition of primary care providers, clinics, policymakers, and community organisations to bilaterally communicate the impact of the existing policies. Because policies, sometimes the best policies don't also translate very well into practice. So this was very important. They put together a coalition of stakeholders, very much PCORI style, to really get to grips with the impact of existing health information technology. And then with the Project Thrive, which is on mental health, they involved patients, providers, and administrators to inform the intervention design through key informant interviews and focus groups. So I just wanted to give you a sense of how research questions can be and are being informed. Research questions which are about addressing health equity can be informed by patient providers and practice administrators. Okay, have the next slide. And what's also nice about this is that these are two examples. These are project information sheets from those complicated projects, which were designed to explain the process to community members, community partners. And I think this came out yesterday when we were talking a little bit about how we communicate. You know, Dr. Padella was talking about sermons, and he's talking about flyers and information sheets. And I do think the single page summary of projects is really important. Being able to visualize things very simply and explain what a project is doing is very important. So I just wanted to share those examples, which I thought were, particularly the Project Thrive. I like it's a journey. You can see it's a journey, and it's got its phase 1, it's got its phase 2. But these sort of things are very good mnemonics. They're very helpful for you to remember what we're doing, which is because it's complicated. The project's complicated, but they're also very helpful for people who are you're explaining the information for the first time to as well. Okay, if we have the next slide.
Yeah, I just want to add something here, Dr. Rebecca, if I have your permission.
Yeah.
So we have a basic that I put together. It's not very good, a basic graphics of EM part. And I am sure that the here, all of the cohort participants, all of you have phenomenal experience and really are very good with how you work these things out. And so we definitely need to put a sheet together as for the EM part, which can be standardized across the mosques, and we can use that as so we have a very basic diagram. If you like my schema or graphics, we can start from there. If you want to come up with completely your own, by all means, we can do that too.
Sounds good. Sounds good.
Great.
Okay, so that was all sort of a bit of background too, because we're in this thinking about how we're planning really. This is all about us planning and sort of thinking about what we need in order to progress. And what we're doing is we're doing the pre-engagement, the community building. That's what we're doing. Although at the same time, actually, as we're talking through all these things, we are beginning to anticipate partnership and infrastructure as well. So these are but this is before anybody's thinking about a topic or funding. We're talking about this engagement, and that we're taking the time to do that properly and respectfully and transparently and honestly. So so we're in this planning phase, and so okay. So next slide. And PCORI is a methodology, and it has standards. So Fatima and I just wanted to sort of give you an idea of, and in my mind, standards are like road signs. So they're helpful. They're supposed to be helpful. They're not supposed to be, I'm obliged to do this. They should be helpful. Okay, so let's give you an example of some of the standards, and you don't need to know all the PCORI standards, because there are standards for the different types of research in terms of sampling and recruiting. But the key ones, I think, are the ones at the beginning. And I think Fatima, I've listed these. If we have the next slide.
Yeah, I actually added a slide right after this. So
okay, go ahead.
That's what it looks like. So I added this to let people know that if you turn those pages of the book, it's actually a manual. So if you turn the pages, this is what it looks like. You can print it out. I've actually printed out my own copy. It's only 18 pages, but it really helps.
Mm-hmm. Okay, good. So so I just wanted to highlight. So they had the standards which I think are particularly relevant for us are the standards for formulating research questions and the standards for patient-centeredness. And the ones for formulating, you'll see why I'm thinking that they're relevant. These ones are relevant to us, because identifying gaps in evidence, we're beginning to do that. We're identifying specific populations, because we're having that discussion about how we describe people. Are they vulnerable? Do we want to describe them as Muslim? How are we describing people? So we're identifying specific populations and also those health decisions, which may or may not have been affected by old research and might be affected by new research. And we're beginning to identify and assess participant subgroups. So if you're particularly interested in the impact of religious belief on health, that would be an example of a subgroup. The religious beliefs and cultural the cultural context impacts. That would be a sort of you could think about that a participant subgroup. We're not doing these other things. These other things are a little bit more sort of in the hands of researchers, so you don't have to develop a formal study protocol. But you are the eyes and ears on the ground, and so we're going to explore the gaps in evidence. Once you've been assigned your mosques, we'll explore the evidence which is in the neighborhood, and we'll have a look at the Chicago Health Atlas and the Illinois community map. And we'll think about what the evidence is telling us around those areas. So we'll continue with what we've been looking at. Okay, and then the other methodology are the standards for patient-centeredness. So if we have the next slide, that'd be super. So this one is so that these are their standards. So engage people representing the population of interest and other relevant stakeholders in ways that are appropriate and necessary in a given research context. So that's what we're doing. We're starting off with the stakeholders, the mosque leaders. But I think as we work through, we might decide that one of the questions we want to ask the mosque leaders when we meet them is that we would like to meet some of their community members and talk to them about who those might be, in order to sort of continue our asset mapping with them. Okay, so those are I think that's the main one that we're doing. The other ones, recruitment, study participants. That again will probably be researcher led, because particularly if you're doing clinical trials, these have to be approved by the IRB. There are certain sort of processes associated with selection and recruitment. So I don't think we're going to look at them. We might touch on the patient-reported outcomes, because, as it says here, when patients or people are at risk of a condition, the best sort of information, of course they are. And patient-reported outcomes doesn't have to be a survey. It could also be people sharing information about what it's like to have a condition or to be at risk of a condition. Okay, so if you have the next slide, those are the two standards that we're doing. So, and this is pre-engagement. If we just try and think about PCORI and health equity, so these are all I wanted to just show, these are the national priorities that PCORI came up with. So these are all these sort of these are the areas that there are projects going on in. There's assessment of prevention, diagnosis, and treatment options. And as I said, it's comparative. So they're comparing assessments, often usual care compared with an intervention or a treatment. Or it could be something like with this one, it could be aspirin. It could be aspirin, dosage of aspirin would be different sizes for different populations. Different doses of aspirin for different populations would be a comparison. They do focus on improving the healthcare system and communication and dissemination. They really understand the value of talking accessibly, and there have been projects which address disparities as well. So in terms of midstream, upstream, downstream, where do you think PCORI is in the health equity journey? Do you think it's upstream, midstream, or downstream?
I think it's working on both midstream and downstream.
Yes, I would agree with that. Yes, yeah. Why do you think that, Hassan?
Well, like the first part, like assessment of prevention, diagnosis, and treatment, that would be like downstream. Mm-hmm. And then like communication, dissemination, and addressing disparities, that would be like midstream, I think so. Yes, they're addressing disparities, aren't they? They're not sort of, they're understanding the differences. They're sort of not quite pushing up yet to the upstream of changing policies. Yeah, I would agree with that. That was my assessment as well. And I think they're moving a bit more now with the policies, but I'd love to see a policy change as a result of some PCORI research. Okay, so if you have the next slide. So yes, and this is an example I think which illustrates what Assam has just said, because they've been trying to show how what they're doing. So they're showing how they're identifying evidence, they're identifying gaps, and then they're sort of having an effect. So this is a visualization of. Basically, they were looking for evidence that mobile health made a difference, and they looked at text messages, they looked at mobile apps, they looked at all these different things to see whether these sort of techie things, like you remember I showed you the Institute for Minority Health. So these health technology which might help. So I did a survey. They did them of all of the projects which had used health technology. So I did a search, and if you go to here, you can see this and do your own search. I did a search for all age groups, all conditions, vulnerable populations, all functions, health utilization, access, quality of care, and quality of life. And basically, this then sort of number crunched all the projects that were in the system, and it tells us that there is one project that has had a positive effect, that it has definitely shown that it has impacted health, and that was a text message project. So that one, you could possibly think of that one as being upstream, because that one is actually sort of supporting a particular type of policy. It's always saying there should be text messaging works in many ways, whereas these other ones is a little less clear. So yes, so I do think they're midstream and downstream, but with occasionally they managed to do one of these breakthroughs like this one, and the text messaging was shown as having an impact on the health of this group, these categories. It's not a great search category, unfortunately, because all age groups, all conditions, that's quite big, but it did include vulnerable populations at least. Okay, so if we do the next slide.
Oh yes, I wanted to just share a slide for Andy because she did a lovely introduction to the doulas, and I actually found a doula project. So there is a project partnering community doulas to improve maternal and infant health equity. So have a look at that one. And when I was looking on those websites, there's also a network for. There were some good networks there, and they looked like they were getting. There's a national maternal health PCORI network, which is just running for 2 years, and they're trying to sort of reduce mortality from maternal mortality amongst which is very clearly an equity issue and a health disparity, and that there's a bit more information there. So yeah, thank you. So I think next slide. I think. Okay, so now I'm going to hand back to Fatima to sort of talk about really how we go forwards, really how we move from the community into a project, as it were. How does what is it that we're doing with data outcomes? How does that help us? Why should we evaluate that type of information?
Thank you so much, Secretary Rebecca. As always, it was a brilliant session. I enjoyed it thoroughly, by the way. It really is. It's a wealth of knowledge there, and you're putting things now. I'm seeing now after the 6 painful sessions of information overload, it is coming together. With Dr. Padela's, session is starting, where he's setting up the stage for what the community is, and now you are telling us exactly what to do with the community when you have it, and alhamdulillah, we're moving forward nicely now, alhamdulillah. So it's really it's very freshening to see that. I'm not gonna overload again with people with the project management information today. We're gonna take it possibly in the next, and I think I actually was thinking of doing more practically, because we would be doing a lot of practical things with the outreach. So as we move forward, those tools from project management are going to play a very critical role in how we move forward. So it would unfold itself without me actually telling you what it's about. And you will learn it as you see it happening. So that being said, here I would like to continue with the thought that Dr. Rebecca has for today, and working with the communities, at mapping the assets, thinking about these relationships that are pre-existing and post-existing from the project. So if we look at what happens is we're working in the community constantly. All of you have been engaged in, and these are every nonprofit organization actually has programs. So these programs go on and on, irrespective of the years, irrespective of the funding. And every year, perhaps what they would do is measure how many people they have served. What is the impact they made? ICNA actually is Islamic Circle of North America. That comes out of their metrics every year, telling us this and this. IMANA does too, Islamic Medical Association of North America. They do too, that they have their physician have served X amount of patients in such and such country. And for example, once they went out a couple years ago, they did a SMILE project where the surgeons went out or emergency room physicians went out, and they did 200 surgeries for the bilateral with the cleaved lip for the kids. So they did this in the field, and it was a great project to see. So this metrics come out every so often. So now, how do we differentiate between a program and a project, and exactly how do we attach the funding to a project so we can go on and make the impact and show the impact? Actually, not only just show the impact, it also translates into the peer-reviewed journal publications, and then you actually are adding to the body of knowledge. So contributing to the body of knowledge is really, I mean, to me, that's one of the highest achievements that you can have. And all of you are actually very much interested in that aspect of the journey. So I want to have this this word evaluative thinking. So that's what we were taught or when we do projects or programs, that whenever we are trying to do a community program or a project, you start with evaluative thinking. What is it? So it's basically whatever you are doing, you are trying to evaluate, not just you are doing it to make yourself feel good. Those are called feel-good projects, by the way. There is a term for that. Oh, see, we did 10 health screenings in that particular mosque. Or wow, there's a diabetes management program out there, and there are 20 physicians that are there that are ready to roll this diabetes management program out. How many patients are you getting? How many patients are you actually helping out, and in what amount of time? So when you attach the outcomes to it, that becomes the evaluative thinking. And alhamdulillah, I mean, it's beautiful to see that we have a lot of efforts in our community, in Muslim community. There are a lot of efforts in there, and many organizations are doing a lot of different projects. However, these projects are not creating or not reflecting or showing the impact. We have many free clinics that are out there that have helped out a lot of patients on board, but have we been able to show the impact? And I'm very sure that if they count their numbers, if they talk the terminology, and if they start with an evaluative thinking, the particular, let me go back here and saying that the formulating research questions, so identifying a gap in the evidence, identifying a specific population and health decisions affected by research, and identifying and assessing participant subgroups. If we just start with identifying these things, writing it down, and saying that this is a particular impact that we would like to generate, here are the outcome measures, and this is what we want to do, I'm very sure that it would end up in a peer-reviewed journal. So the very first thing we have to do is start with an evaluative thinking. So why should we bother? As I told you, that there are, and we have, Dr. Johnson has been telling us that there are areas or topics of interest. We know that we keep doing surveys, we do pilot studies, we do community programs, and we do data collection. So all of this is currently going on in our community. All we have to do is attach that with a theory of change. That's what we need to do. And how do we attach that particular? So all of the work that we do, we actually put it into a format. That's what I'm saying. So we are attaching labels, we are attaching a particular methodology thinking to what we are doing. So a theory of change, or you have heard about the logic model, and so what happens is when we are interested in, or we have a program, we say that we're doing X amount of activities. For example, we do 10 screenings in these amount of mosques, and we want to get X amount of diabetes patients. So now we've done the screenings, we've gotten into the mosque, we got the number of patients. Then we put the intervention in place, and there are specific timeline attached to it. And so, as we say, we are going out and doing these outreach, and so all of these activities that we are doing and attaching it to the measurable outcomes, that measurable outcomes in a specific time range turns your program into project. Okay, so let's hear this again. All of the work that you're doing, if you convert that work into measurable outcomes, and you have to start with some assumption. You have to start with, this is what you want to measure, just the basic thoughts. and you have a measurable outcome that converts a program into a project. When you have those variables, I'll tell you, and I can assure you, in fact, that you will receive funding. And that's how you can convert a community-based organization to put them into a perpetual funding model, because you keep on project after project and after project becomes your impactful program. So you have planned activities, you got intended results, and that's what the theory of change is about. So you literally create behavior changes in a particular population or in a particular community. And Dr. Johnson was talking about the downstream and the midstream, and that's what's happening with the midstream right now, that we are measuring these at a community level. There's a very nice graphics actually from Kellogg's Foundation. It's coming up. I loved that one, and I said, wow, and it kind of reflects that idea of midstream, upstream, and downstream. But again, you take your impact and you feed that back into your outcome, into your planned activities, and there you go. Or you take your impact, you put that into a paper, and you go to a funding body, you say that this is what it is, it feeds this way into the next cycle of and you have identified another gap. There you go. You have a project, a proposal, a grant proposal, in fact. So this is how we can actually, and then again, so evaluation is the key to measure the changes brought by your work. And again, we have certain measures with, let me go to this one first, and I'll come back to that one, to the next slide. So we have key measures for eMPART project as well. These are the 12 indicators that we have told PCORI that we would be measuring. And if you look at it, can anybody tell me whether we are doing downstream, midstream, or upstream here? We have, let's go over the measures. So we are measuring pre and post assessment of your trainings to assess the effectiveness of our training program. And that's why on Saturday, I'm hoping that we would like to have a poll as well, if you guys want to come over to our Saturday class in presence, or at a physical location where we can deliver the assessment. That's number one measure. The number two, we're doing new stakeholder relationships formed, measured by the constant contact listserv. So we are going to be adding the stakeholder. We already have certain stakeholders that are part of our community, but as we are expanding with all of you, all of you are new stakeholders for us, actually. So your addresses would be into the constant contacts listserv, and you would be the communication would be disseminated through that. The number of healthcare stakeholders that signed memorandum of understanding committing to the PCOR mission. Number of attendees and the demographic characteristics of the attendees that are contacted during the outreach. So how many people we're going to serve during that 4-month period or 3-month period. Number of people provided community health education at each of the outreach session. So as you meet people, you're going to talk to them about, Javeria's example today was great, that she spoke to people where she made and how she advised some of the people, or so all of those, each factor there, Javeria, we have actually put in as an outcome measure for the eMPART project. See, that's what we did. You guys do this all the time. All I'm doing is I listed that as an outcome measure. This is beautiful. See that? So that's what we are doing. We're simply counting these numbers. Number of people provided informal counseling. I'm sure you're going to direct people to many different places. You're going to say, oh, your issue, actually, you really need to go see a specialty care provider. Here's a list. My asset map says this is the ophthalmologist here that you need help, and I'm going to refer you to that ophthalmologist. We don't know who that is. We don't know which community you're serving, but it would all come together as we take this project step by step. And number of people provided social services support at the outreach. We have So the number of people could not be helped, and they were referred to worry-free community. At the last resort, what you would do is say that, you know what, I really don't know where you need to go or what you need to be helped with. I'm going to refer you to the community office staff and see what that is. That actually would be a good measure to see that how many people come that way, and it would tell us that our training program, where our training program still lacks in its information and in its training or in the knowledge. So we don't know that yet, but I think that I'm hoping that the outreach results are going to put us in that direction. And I really okay, going back to the 9th measure here, evaluation of data from asset mapping surveys. And that's a measure that we would do in detail. And Dr. Rebecca is going to guide us on that on that measure. Number of community health town hall attendees. So when we do the community health town halls in the month of March, as you develop into this project and move from the training phase into the stakeholder phase, all of a sudden, every one of you are going to see that, wow, you have made these beautiful connections. You have strengthened your established connections already, and you are actually making an impact. You're going to see it right away, inshallah. And from there, you're gonna all of these relationships will culminate. Will actually have a show and tell on the you would have 2 show and tells. One of them with the community health town hall that's happening in March. It is crucial that that happens in March. Why? Because April is the month of Ramadan, and as a routine practice, worry-free community does not do a lot of community events in Ramadan, because we actually, even though we're not a faith-based organization, but we do recognize that wellness and health has a lot to do with internalizing. And when you internalize, either by sitting down and reflecting on yourself, meditation, or through prayers, that actually brings wellness, not just to yourself, but as healthy being, but also to your life, to your relationships, and the environment itself. So we would, inshallah, that's why we do not plan any activities during the month of Ramadan at all. But we do keep in touch. We provide support whatever we can. It's not like we're shutting down or we don't have any phones, or we do routine operations, but we don't do any additional work at all. So I'm hoping that you would start planning for Ramadan, and you would use that time wisely as well, but finish up everything before Ramadan. And Ramadan is a quiet month for reflection and gathering ourselves together. And then come May, we would go back into the community, and we would actually start to get ready for the June conference. So in 2019, we had a conference that was our first Picori conference for mosque community. And we are hoping that we would have another conference in 2021 in June, inshallah. It's actually bundled as a part of the project. So that's another deliverable we have. We would do it. And that's another show and tell for you. And that conference is at a national level. So the previous project folks are also going to be at that conference. More than likely, it will be a hybrid between a smaller event and then virtual relaying of the conference across the nation. So many people can participate. I think that's the best way to go. And of course, all of us would be probably be present physically, unless you guys decide to go other way and you want to go completely virtual. That's totally up to you, however you guys want to do it. And then the last evaluation measure we have is that we want to hire some this particular program or project that we are starting. The first part of it ends in July. What we want to do is then hire the community health workers that come out of this training program. Whoever is willing and interested, they can apply with us, and we would love to have the community health research folks as a part of the ongoing research project/programs with worry-free community. And then that the impact analysis and the evaluative measures from this project, where we want to put that into the next project. And I don't know what that would be like, but in the next few months it should come pretty clear to us that which direction we want to go to, and start thinking about the second grant proposal that we would be going from this point on, because you are doing a lot of really good work, and we can add more organizations to it, we can add more staff to it, and we would move on. So I hope it's clear that how a project is transitioned into a program. So inshallah, we would learn more about it. But when we distinguish between the two, the project versus program, it becomes very easy to do the rest of the things with the outcome measures and these assumptions, and having the area of interest and doing the planned activities. It could be any different things. Our planned activities from this particular project is actually a training program, and then we are doing a town hall meeting, and then we are doing outreach activities, then a town hall meeting, and then the conference. Those are all planned activities for this particular program. And then we're doing the data collections, and you just went through the list of outcome measures that we have. And once we do the outcome measures, after the conference that happens, we will analyze the entire project for its impact. And inshallah, one of the measures that we have as for the impact is whether we can come up with a community advisory board out of this project or not. So that advisory board, it's up to the community. And that is the best measure for our work. If we, with all the work we are doing, can make a change in the thought and can make a change in the behaviors of our community leaders, where they can see a need to have a community advisory board that serves PCORI's mission, or that serves patient-centered mission, then guys, we have done our job. This is a successful project. That's what the ultimate success measure. PCORI may not measure us that way, but to me, that's the ultimate measure that I have in my mind. My personal bars are always higher than what we put into the proposal, but that's the ultimate measure. If we can change the minds, or if we can show the light to our community leaders, saying that, please, let's come together and form a community advisory board that serves the patient-centered mission for the Muslim community, that would be the ultimate blessing we can have in form of impact out of this project. So let me go over the last slide here, which is this slide actually came from the Kellogg Foundations, and it's very much of a replica of what Dr. Johnson was talking about, the downstream, midstream, and the upstream. So you start from an individual. The individual data goes into the program. The program data are collected by the organizations. The organizations, for several organizations, come at a community level, and then from the community, those findings go into the policy, and the policy we actually get to the larger formal systems, because that's when you are actually making a change in the formal system. See? So that's the journey we are all on. And as we go higher and higher, the complexity of the methodologies increases. So it is very easy to, knowing that you have this particular slide, and knowing the Dr. Rebecca's idea of upstream, midstream, downstream, where do you think, at what level are we collecting this data? Anybody? Okay, I want to see what's midstream, downstream. Okay. Yeah. Yep. Thank you. So, Dr. Rebecca, do you think we can we are able to make the impact? You think we can do that?
I do. I think we can.
Thank you again, guys. It's been a pleasure. Thank you. Yeah, so hopefully we can, let me see if I can. So that's with that. Let me still, any questions that we have in session 9 tomorrow? We are going to be doing the outreach, orientation to outreach, and Dr. Rebecca would be leading that as tomorrow. Thank you again, Dr. Rebecca. And then Wednesday to Thursday, Dr. Padela would come back to us and he would talk about how do we, so the principles that we've learned today and tomorrow's, we're going to, those would be input for Dr. Padela's session on Thursday, while we actually, where we learn how to conduct an actual mosque PCOR study in a mosque setting. Any questions? Any questions that you guys have? So how many people would like to join in person on Saturday, the 24th? That's the last Saturday of the month. So we want to open the doors and have you come in to the Glendale Heights office. How many people would be willing to travel and be there in person? If I can have a quick poll, that would be great. I know several of you wanted to. Okay. Okay. That is actually Saturday, the 24th, and it would be from 1 o'clock till 2:30. So it's Saturday, the 24th, not coming Saturday, and it would be after that Saturday. And I think it would be nice if you guys can be present. We would like, I would, if majority of you would like to show up, then one of the things we really want to show is give you the assessment for the training, and because this was supposed to be in person, and that is part of the reason why we couldn't do the pre-assessment, because a lot of the things you could do in pre-assessment is that you could Google the answers, set it in, and then what's the point of having a pre-assessment? So we wanted to have the assessment in person, so that would be a big push that we are hoping that you guys can join. So we would actually send a doodle poll out. Masood, if you can make a note, either Masood or Bilal, if you guys can make a note to send a doodle poll out for Saturday, the 24th, that would be great. Thank you, guys. And we would be looking forward to seeing you tomorrow at 5. Thank you, Dr. Rebecca.
Okay, bye. Bye-bye.
Back to tomorrow. Thank you. Goodbye.